Welcome to Med Madness, your trusted source for USMLE Step 2 preparation. Today we're diving into a critical and potentially life-threatening condition, heparin-induced thrombocytopenia, commonly known as HIT. This topic is essential for medical students and professionals alike, as understanding HIT can significantly impact patient outcomes. We'll explore the definition, causes, symptoms, diagnosis, and management of HIT, and conclude with a real-world case study to bring these concepts to life. Next, let's discuss what this condition is. Heparin-induced thrombocytopenia, or HIT, is a serious condition that occurs when a patient's platelet count drops significantly after exposure to heparin, a commonly used anticoagulant. Typically emerging 5 to 10 days post-heparin exposure, HIT affects up to 5% of patients. The underlying mechanism involves heparin forming a complex with platelet factor 4, which then triggers the immune system to produce HIT antibodies. These antibodies bind to the platelet surface, leading to their activation and removal, which paradoxically increases the risk of thrombosis. Next, let's move on to the symptoms and clinical presentation. Patients with HIT often present with a drop in platelet count exceeding 50%, usually accompanied by symptoms such as arterial or venous thrombosis. Necrotic skin lesions may appear at the heparin injection site, and some patients experience an anaphylactoid reaction following heparin administration. Clinically, HIT is associated with mild to moderate thrombocytopenia, rarely dropping below 20,000 platelets per cubic millimeter, and paradoxical thrombosis, such as pulmonary emboli, can also occur. Now, let's discuss how this condition is diagnosed. Diagnosing HIT requires a high index of suspicion, especially in patients with recent heparin exposure who exhibit thrombocytopenia or thrombosis. The serotonin release assay is the gold standard for diagnosis. Additional diagnostic tools include screening for HIT antibodies and clinical assessment of platelet counts and signs of thrombosis. Imaging techniques such as ultrasound or CT scans may be employed to identify thrombotic events. Next, let's move on to the management and treatment of HIT. The cornerstone of managing HIT is the immediate discontinuation of all heparin products. Patients should be switched to a non-heparin anticoagulant, such as fondaparinux, which is particularly safe for use in pregnant patients. Management also involves careful monitoring of platelet counts and thrombotic events. Complications can include severe thrombotic events if not promptly treated, underscoring the importance of early intervention and appropriate therapeutic strategies. Now, let's look at a brief case study to illustrate these points. Consider a patient presenting with sharp chest pain, which worsens with inspiration, alongside tachypnea and decreased breath sounds over the right lung base. This presentation is highly suggestive of an acute pulmonary embolus due to HIT. The patient's history reveals heparin exposure starting 7 days ago, aligning with the typical onset of HIT. Upon diagnosis via serotonin release assay, all heparin products are immediately discontinued and the patient is started on fondaparinux. This prompt intervention leads to a gradual recovery, highlighting the critical role of early recognition and treatment in HIT management. In conclusion, heparin-induced thrombocytopenia is a complex but crucial condition to understand for any medical professional. Early diagnosis and management are vital to prevent severe complications. We encourage you to engage with our pre- and post-podcast quizzes and Anki flashcards to reinforce your learning and ensure you're well prepared for your exams. Thank you for tuning in to Med Madness, and we look forward to guiding you through more essential topics in your medical journey.